All right. Good day, everyone. And I'm excited to be part of this year's National Family Planning Conference. The name is Femi Quaitey, and I'm presenting on behalf of all the authors of this particular paper and also for the affiliated institutions, Pathfinder International and ExpandNet. The topic of my presentation is planning and implementing the tax shifting policy in Cross-River State using the ExpandNet WHO scaling up framework. Now, at about 2014, tax sharing was already being implemented in the country, in Nigeria. But it was being implemented in various clusters across the 36 states of the country, and it wasn't an even type of implementation. So some states had began the process of domesticating the policy, and some states had gone beyond domestication and had started looking into how to implement the policy. So some operation research was conducted by the Evidence to Action Project and Pathfinder International between 2015 to 2016 to test tax shifting implant provisions to choose in Kaduna and Cross River State. And there were positive results because at the end of the research, it was seen that choose could actually provide implants, that is, do the implant insertions and also effectively remove the implants. Pathfinder, together with the Evidence to Action Project, of course funded by the USAID, went forward to establish a state-led resource team in 2017 of various family planning stakeholders to guide the operationalization of the policy using the ExpandNet WHO framework, which had a 9-step approach for scaling up the tax sharing policy in Cross River State. Now, from the training which was anchored by ExpandNet together with Pathfinder International, it was discovered that there were 4 critical components for the scale up. So it was identified that choose needed to be trained in implant insertion and removal, as well as community mobilization and demand generation efforts at the community level, which needed to be intensified to build the confidence and to make sure that women in the communities as well as men knew that choose could now provide these services. It was also identified that supportive supervision had to be routine and constant to be able to monitor the quality and also ensure that the choose that were trained continued to do the provide implants according to the guidelines and standard operating procedures. Also, it was necessary to ensure commodity security, so ensuring that last mile delivery of contraceptives and other consumables was always on point. So for our methodology, we put together a diverse stakeholder team, and it was important to get both state and non-state actors in health to team up together to be able to come up with this scale-up strategy. So we had private sector input, we had non-governmental, civil society, community-based organization, as well as, of course, a very, very, very robust representation from the government side, from the Ministry of Health and other line ministries and departments in the state setup. Also, there were qualitative and quantitative research analysis on the scale-up process, and data was being routinely collected from monitoring and evaluation visits as well as technical assistance visits, which was done with a diverse team of both project staff as well as government employees who were working to ensure that the scale up was being implemented appropriately. Also, we trained quite a number of CHUs to be able to provide long-acting reversible contraceptives, which was key and integral to the scale-up process. So the scaling up resource team was comprised of local and state governments as well as NGO actors. So, and just like I said earlier, there was a study which had 12 focus group discussions as well as 10 key informat interviews. And that was able to help us, to analyze what were the main facilitators as well as barriers, to the scale up process during the period of implementation. So to complement the qualitative data, routine SAFES data was collected from the SMGL project, monitoring statistics, as well as the State Health Management Information System, and also the National Family Planning Dashboard. And just like I had said earlier, the E2A and Pathfinder project trained 160 CHUs to be able to provide lags. So our results, the resource team had developed a very, very robust strategy document, which helped to guide the scale-up process. Initially, when the project started, there were ideas of training a certain number of trainers to be able to provide step-down trainings, but as a result of the scale-up team and the strategy document, which was developed using the ExpandNet WHO framework, it was identified by the team that 14 new master trainers should be trained as against a smaller number which was initially identified. Also, 160 CHUs were trained to provide long-acting reversible contraceptives as compared to no CHU being trained in crossover at baseline. So also from the qualitative reports, many respondents noted that they observed an increase in women seeking family planning services, which possibly could be linked to CHU's improved family planning counseling capacities and increased confidence in CHUs. It's very interesting to note that as at the time that the scale-up implementation was starting, CHUs had not been providing any implants. Implants were just being provided by nurses in crossover state. But at the end of the project, there were over 3,241 implants that had been inserted by CHUs that were trained, during this scale-up implementation. So these are some of the excerpts from the focus group discussions that were had. I'm going to take some of them. There was one from a trained CHU in Northern Crossover, said, I learned so much because the training has helped me. Now I can do the counseling, have the patient make informed decision, and perform the insertion properly. Also sterilize medical instruments as well as keep records of my activities, because we were taught how to document our activities. So it's very important to note that when CHUs were being trained during the scale-up implementation, emphasis was not just on the insertion and removal procedures, but also ensuring that proper as in documentation was done, and also ensuring that services were provided in an integrated manner. So we had the focus group discussion also was able to take a response from some policymakers, and so we have one here. I think the tax shifts in tax sharing policy is very important and appropriate at this time when we have a dearth of healthcare workers. We cannot expect that because we don't have enough doctors and nurses, we will not train the personnel we have to handle cases, or that our mothers should die. So I just think it is the best we can do considering the circumstances we find ourselves in. And generally, from what we saw during implementation, it was key that a lot of health policymakers were in support of continuous implementation of the scale-up process. So at the end of the project, it was important that we came up with some recommendations, and we The project team as well as the resource scale-up resource team identified that it was necessary to adopt a decentralized LGA-based step-down training approach, which will be supervised by the state, and also for the state to commit funding from the Saving 1 Million Lives family planning component to train more CHUs, because of course there are more than 160 CHUs in Cross River State. Also, it was key to have continuous routine monitoring and evaluation, as well as technical assistance visits, and this was key to ensure a strong quality control plan. Also, it was identified that it would be necessary to, build capacity of state actors on the scale-up process, as it equips them to guide the scale-up process effectively. So, in conclusion, what we discovered was that when we're able to plan systematically for scale up, and of course, using the very, very key guidance that we were able to get from the ExpandNet WHO framework, and also working together with the state family planning stakeholders. Here, the state in question was Cross River State. It was able to help get all the productive results that we showcased on the project, and it is an approach that can and should be replicated elsewhere in Nigeria. So, at this particular point, I come to the end of my presentation, and thank you for listening, and I'm open to your questions. Thank you.